Our first speaker will be Dr. Dexter Speck from the University of Kentucky, and he will be speaking on strategies to teach GI physiology.
Well, good morning and welcome, all of you that are bright-eyed and chipper here at 8 o'clock in the morning. We were down front looking at you meandering in, and it is very much like I often get 8 o'clock lectures to the medical students, and they slowly filter in, and if you get a third of what you expect, you're thrilled and excited and ready to go. So Jenny told you that I was going to talk about strategies on teaching the GI system. As I got this ready, I kept chewing on it and ruminating over, what really goes on and what do I know from teaching GI physiology for 34 years. And so I'm going to tell you a little bit about that and breeze through those slides that she wanted us to do, but they'll be used later. I've got to start out by telling you a little bit about my background and pose this question that, how does a neurophysiologist and a respiratory neurophysiologist at that wind up teaching GI physiology? And I said yes to a request to teach, and 34 years later, most of the people at the University of Kentucky know me as the GI guy. Despite the fact that my expertise and my research was in the neural control of breathing. And so how does that happen? Well, many of you, some of the younger ones of you that are looking for a career, you never know what you will be asked to teach. And so it is important to be able to sort of broach new territory. And I want to encourage you to do that. I've been able to teach gastrointestinal system to many, many different levels of students over the years. So as I was ruminating about this topic and what I would tell you guys, what advice I would have for you, I recognized that my own evolution of teaching, the way I go about a GI course, has changed considerably over the years. And most of you, as I look across the audience, most of you appear to be of an age where you learned your physiology in a traditional lecture format, all right? And that was typical through the end of the 1900s, that was the way that we taught. And most of us have had very little formal educational instruction. We just teach because of the way in which we were initially taught, right? What we enjoyed is what we tend to do. That traditional lecture format was what was in place at the University of Kentucky when I got there. The former instructor for GI physiology was a surgeon, actually, and Ward Griffin took a position at another university, and there was no one doing GI physiology within the Department of Physiology. So as the young guy on the block, I was asked, can you teach GI physiology? And I said, sure, whatever. Our physiology course was, at that point in time, our medical school curriculum was a traditional medical school curriculum where you basically had 4 hours of lectures on different subjects as you went through, and there was very little coordination between courses. Many of you experienced that in your own educational process. We had about 100 hours for the GI physiology portion. Let's see if I can make this thing work. It'll help if I point it the right direction. All right? And so the GI portion really accounted for about 12 hours of that instruction. So how do I get everything these future physicians need about GI physiology into their heads in a 12-hour period of time? Well, we all realize that traditional lecture format can get pretty boring. And if I continue to drone on like this for the next 45 minutes or so, recognize that you guys are going to have some issues with that as well. So how do we change that up? What do we do? Well, active learning became the buzzword. And so in the 1990s, we sort of changed our curriculum to one that involves some active learning processes. And we could quibble a long time over what active learning is and what that really means, but I like the very simple definition of anything that engages the student and makes them participate in the learning. And so one of my goals here as we go along today is to get you guys involved in this a little bit, to get thinking about how do I pull students in. Now, the first issue is how do you get them to the front of the room? And despite Jennifer's efforts here to bring you to the front, it helped, and you guys are doing pretty good, all right? Nobody's sitting in the very back row. That's pretty impressive, right? We went with this active learning model, we went to a block course structure where we now had physiology for 4 hours a day, okay, for a period of 9 weeks. Of that physiology block, I had about 17 lecture hours committed to GI physiology, so I actually got more time to participate and to draw students in. That allowed me to basically add some more, I keep turning that, there we go, to add some more integrative activities, a lot of pathology, disease states, application. And so we started with, trying to get the students engaged a little bit. And to get you started this morning, so that I'm not just passively pouring it into you, I want you guys to participate a little bit, all right? And so one of the questions, when I get to the how do you swallow portion of the course, I'll tell them a little bit about some of the mechanics of swallowing, show them the list of nerves that are involved and all the different muscles that are involved. But then I'll ask the simple question, how do you swallow? So you guys all be star pupils here now, all right? And somebody shout out, how do you swallow? What do you do? Oh, perfect response. You guys are just like the medical students. Someone be brave. How do you swallow? I just swallow. Well, you re-asked the question. That's good. All right, so I'll ask a little different question. Everybody swallow, all right? Now, what did you do to swallow? Personal experience, what did you do? Close your mouth, okay? That's a good start. That keeps you from, having anything fall out. What else do you do? All right, so here's the task. Now, I want you to swallow 5 times. Everybody, swallow 5 times. Put down your coffee, all right, and swallow 5 times for me. All right? Come on, let's do it. All right, at this point, usually the classroom starts to chuckle a little bit. How many of you managed to swallow 5 times in a row? She did down front. She's drinking coffee. She's cheating, all right? But that's okay, cheaters are good. They can be instructive as we think about this. How many of you made it to 3 swallows? How many made it to 4? Now we're down to just a few. Are you guys drinking coffee back there? Are you eating a bagel or something? Chewing gum? Inevitably, if someone has made it to 5 swallows, chances are they're either eating or drinking, or they're thinking about eating or drinking. They're looking at their watch going, when's he going to be done so I can go get a bagel now that he mentioned it, right? So realize, at this point, now you guys know an important thing about swallowing. How do you swallow? You need to collect something in your mouth, right? A lot of people will come up and say, well, I press my tongue against the roof of my mouth, or I press my tongue against the bottom of my mouth. What are you doing? You're trying to stimulate release of saliva, and then you capture that saliva, you move it to the back of the throat, at which point you're capable of initiating the reflex portions of swallow, all right? So after I do this, and after I get them to recognize that, hey, if I just do a swallow, it gives me a whole lot of information. I don't have to memorize all that. When I have a question about swallowing, I can do it and figure out what I'm doing, all right? Now, I realize here I haven't started my timer, so I need to look here to see how we're doing for time, and I'll keep track of that up here. All right, so as we are swallowing, you know, that sort of sets a framework. Then I'll go back through and I'll talk, and many of you that have done this, you know, you've talked about the different phases of swallowing. And hopefully you realize that once you get past that oral phase, where you've initiated the swallow voluntarily, it becomes a stereotype movement, and it's all or none. Now, everybody try to swallow, and then once it starts, stop it. Do it. Humor me. Come on. Participate. You guys are just about as hard to get cooperation from as medical students, and you know it, right? Maybe that gives you an appreciation for why your medical students don't want to participate as well. But I encourage you, you know, try. And what you rapidly realize is, once you get to that point that you've initiated a swallow, it's out of your control. And so I can talk about it as being a stereotype movement. Now, I will go on a little bit farther and tell you that because I am a respiratory neurophysiologist, I realize the importance of making sure you're not doing GI-related behavior and respiratory behavior at the same time. So an important part of the swallowing reflex is shut off whatever that respiratory control system is telling you. It's wrong, okay? And so I do a little demonstration. Like most good college students, I learned lots of useful skills in college. And one of them was slurping Jell-O. To slurp Jell-O, you take a nice industrial-sized cafeteria piece of Jell-O, and you lubricate it a little bit. Why do you lubricate it? Because you're not going to chew it. And to swallow anything, lubrication is important, right? So you wet it down. I was going to do this for you, but I realized it was a big room, and you guys would all be sitting in the back, and it's hard to see that piece of Jell-O up here, all right? But basically, I would have that piece of Jell-O, I'd have it lubricated, and then I inhale as hard as I can. I usually ask students beforehand, does anyone know Heimlich maneuver? Anyone have any CPR training? Because one of the things is about swallowing, you guys all know, what happens to your ability to swallow effectively as you get older? It gets less and less. Old people have more problems with swallowing than young people. And I'm getting old, all right? So recognize, I lead them up to this point, and then I say, okay, to do this, I'm just going to inhale as hard as I can. I got to generate a lot of force here to get that giant chunk of Jell-O into my mouth. And I will hold it up, and I will go, counting on the fact that as soon as that Jell-O hits the back of my throat, the tactile receptors are going to send a signal that shuts down inspiration and starts the swallowing reflex. And students are always amazed that it happens. I looked to see if I had a good video of this to show, and I didn't have one and didn't have the time or energy to put one together. But if you get on Facebook and you look at Dexter Speck Jell-O, you'll find one that a student took, okay, of me slurping Jell-O. And they respond very favorably to it. And then I proceed to show them after the fact a video on Facebook, or YouTube there rather, of Stevie Star. Some of you guys may have seen Stevie Star on one of these, you know, America's Got Talent or Britain's Got Talent type shows. And he swallows billiard balls, he swallows light bulbs, he does lots of things like that. And we can talk through that video relating lots of physiology to it. Okay, and so it becomes effective ways to bring real life situations and get them thinking about what goes on with the swallow. Well, we did that for 10, 15 years, and then it was time for another curricular change at the University of Kentucky. And of course, as we hit, you know, into the 2000s, the team-based learning became sort of the buzzword, and this is what we wanted to do. And certainly, there's a good reason to want to have physicians begin to learn to act as a team, to recognize that they need other people, they need other input. And so we utilize some team-based learning approaches in it in the redesign of a course. And so now we have an integrated organ system course. And so it is no longer GI physiology, it is the gastrointestinal system and all of the components that go into that. I do still have about 14 hours, lecture hours, with the students where I can sort of set the framework for what some of the other instructors will do. All with the idea of making these people into lifelong learners. You know, that's our stated objective, that these people will be able to move forward, that they'll be able to continue to learn throughout. And there's a continuing emerging body of knowledge that is huge and hard to keep up with. You guys are going to be very blessed in the next 3 lectures because we have some experts that are going to talk about things where you're going to get some good, solid, factual, and conceptual knowledge that will build on some of the things that, you know, if you're like me, you're not aware of. You know, these are new and innovative things that are important. And we will constantly be exposed to those things as we go along. Well, let me tell you a little bit about what went into the development of our integrated GI system. Very importantly, we spent more than 2 years planning to move forward with this. And we had a committee for each of the different major courses that were going to be involved. And that involved some clinicians that were interested in aspects of what we were doing. It involved some current students that were in the program. We had a couple residents that were involved, and most of those were past students. So they'd sat through the previous GI physiology course, and they had recommendations of these are things that we want to make sure persist. These are things that weren't really so important. We had faculty from some of the other courses and other disciplines. We had over 10 committee members over this period of a couple years with the ideal goal of, you know, deciding what is the foundational knowledge that a medical student needs, okay, about GI physiology, and then also giving them some of the skills and an introduction to clinical practice as well. For each of these courses, we had a clinician who was a co-director, and we had a basic scientist. For our GI course, the clinical person was from the Department of Internal Medicine, and I was the physiologist who was representing the basic scientists. And with these committees and these co-directors, we sat down, we sort of tried to decide what are the topics that need to be covered. Who are the faculty that we should involve? And I will tell you, on our first round, we had 19 faculty for a total of 80 hours. And we rapidly realized that was just too many characters involved, and not all the players play by the rules, all right? And so we did some reevaluation. The methodologies that we used for this course, we had them for 4 hours a day for 5 weeks. We gave 2 exams, and we used ExamSoft for the examinations. As I said, we had 18 faculty involved, 80 hours. We used Echo 360 to capture the slides and the audio. We had an online course platform, which we have used Canvas over the past 4 years. And our initial run was in 2014. It existed, the gastrointestinal system existed very close to the end of their second year. And so March through April, we were really the last major system before they went into step 1 of boards. So what are students thinking in April of their second year? First and foremost, what do I need to know to pass the boards, okay? So we had that going on. And a couple things that I learned very quickly is that I was used to teaching students at the end of first year. These were at the end of second year. So the students are much more sophisticated, much more exposure to clinical medicine and to practice. They knew more clinical skills, and they're constantly honing in on what do I need to know for patients? What do I need to know for patients? As we went through that first year, a couple lessons that we learned. The first was anytime you change the curriculum, you're going to miss things. You know, you thought something was covered, but in this course, but it wasn't. We're struggling with where do we go, okay? What's missing for the students? And so to help solve that problem and to keep things running smoothly in that first year, the co-director and myself, both of us were there for almost all of the sessions. That allowed us to see what was the flow, and it allowed us to see where confusion popped up in the students. That was very important, and fortuitously, I had a couple hours in the schedule that we had left open, and so that was very easy to say, hey, little optional class here, but these are bits that I know you didn't get from the physiology lecture, that you needed to know to understand the pharmacology lecture, that you needed to understand what the clinician was going to tell you. And so there were about a half dozen things that I identified that we just didn't do a good job of making this flow. And so we built those into this, all right, and that was fortunate that we had that class time to do it. But it obviously meant, what are we going to do next year? How are we going to make sure that we have those holes filled? We also had a major problem that developed with consistency between presenters. You'd have people that would talk about a particular drug that is used, and then you'd have the clinician say, oh, we don't use that drug at all because it's got this problem. And so, the question became, how do we make sure everyone's consistent? Well, two things there. We encouraged the faculty to look at the pertinent PowerPoints that the other faculty had provided and to come to some consensus. And we began to develop an ebook. The idea with this ebook was to provide material to these students that would be consistent and would be the major source. We had textbooks, but you know what guys do, what medical students do with textbooks, right? They rarely look at them, and if they do look at them, they're looking for a very specific thing. And so we tried to put together short little files. It turns out I counted before we came here, I now have 77 individual files, mostly related to pathologies. You want to know something about irritable bowel disease? You got 6 pages on irritable bowel disease, okay? And then right away the students said, well, there's 77 files. I don't want to look at all of them. I want it as one book. So we got one of the IT people to go through the trauma of putting those together, okay, so that we had one ebook they could print out, okay? It currently is 280 pages. And very importantly, we made this ebook available from the very first day of class. So it's there, it's available to you, all right? That helped a great deal in making sure that the faculty were consistent, that they were given the same message. We would encourage faculty that are talking about irritable bowel disease, whether they were a pharmacologist or whether they were a clinician, to read through that page and make sure we're all on the same plane, that we're telling the same story, all right? That helped to address the issue of insufficient resources for the students. We have continuing challenges. I told you we've gone through 4 years now. There's obviously, with step 1, they are doing more nutrition-related things, so we got to work a little more nutrition into it. The microbiome is an emerging topic. There are going to be questions on step 1 relating to that, okay, that weren't there 10 years ago. And so, those are going to be things that we need to continue to incorporate into these. We have expanded the use of the ebook, and with this idea of making lifelong learners, we want to decrease the amount of time, okay, that we have the students in class, make them more self-learners. At University of Kentucky, we also have another problem, is that we're opening an off-site campus. We're going to deliver most of the first 2 years to a remote site, and it's compounded by the fact that it's in Central Time Zone, and we're in Eastern Time Zone. So, as hard as it was to get you guys here at 8 o'clock in the morning, what would happen if you were coming for a projected classroom starting at 7 o'clock in the morning, right? You guys are smiling, all right? You understand this just isn't going to happen. So we had to, instead of starting at 8 o'clock, we're going to start at 9 o'clock, so it's 8 o'clock in Bowling Green, all right? And then we have issues of coordination for the TBLs and exams, all those things that we're struggling with getting ready, because that will begin this year, this fall. Here is a sample of our classroom situation, the class schedule. And this, you see, we started November 8th, and the class overview was done by the two co-directors, Lauren Craig, who's an internal medicine clinician, and myself. I had an hour to sort of give them an overview of basic gut structure and function, sort of describing the forest here for them. Not much of the trees, not much of the detail, just, here's the big picture. Here's where we're going. And then we begin with a mouth to anus approach, okay? Going down through what's going on with these various things. And you can see here on the second day, we bring in a radiologist to show them some structure, talk about some of the clinical tools that they'll be using to help to understand GI structure. Internal medicine comes in to talk about some of the specific disorders that are related to the mouth and oral function. And then the second day, we have, again, a clinician who's going to do a little basic development of the gastrointestinal system and give them a little bit on swallowing and describe some of the things that I've gone through with you guys already this morning, okay? Now recognize, one of the things here is our course is structured so they have class through the morning hours. What is your hope that they will do in the afternoon and evening hours? That they will go through the material, they will review it, they'll get ready for the next day. And to help them do that, this is what they will find on Canvas. It says, for Wednesday, November 8th, you should look at these pages in the ebook because these topics will be covered, all right? And these are the handouts for the 3 in-class lectures that you're going to do. So hopefully, and we encourage the students, Tuesday night, look through these. Make sure you got a feel for where we're heading with this. And so they do that, and then, hopefully on Wednesday, we're able to make our way through this. They have some of the foundational knowledge that they have self-studied and learned, and they're ready to start to put things together so we can be a little more integrative. This is the second week, and you see it continues to go along. We are down to where we now have 14 instructors that we utilize, and I went through last semester's course offering and looked, and you can see about half of our hours, okay, about half of our hours are sort of that traditional lecture. We do try to bring some active learning ingredients into it, but this is probably the most important part that they like. And this is getting weaker and weaker. Let's see, can I point this way a little more effectively? No, it's not showing that. All right, so recognize we do these weekly TBL sessions where they are going to, as a team, try to work through. They have the resources. Remember what I showed you, that these are the ebook chapters that are important. These are the handouts. And so they have those available to them as they respond as a team to try to figure out answers to questions. And we do some of that. We do some large group discussions. We use a lot of clicker presentations to foster this participation in the active learning. Our rooms are set up like this, and you can see there that we have 31 groups of students, 4 to 5 students. We tend to set them up so that they're spanning 2 rows. That means the ones in front can turn around, talk to the ones behind. They can communicate effectively. All right? And so, yeah, thank you. So they do that, and we show them a TBL session. We have 20 vignettes, and some of these vignettes are the same case, but the first question will be, what's the diagnosis? The next question is, what do you need to do next? What's the next procedure? And there might be another one, okay, now what's your treatment plan? For each of these, first of all and importantly, we don't give these out to the students. We project them, we require attendance for the TBL, and the way we require that is down here at the bottom. You can see in those sessions, they get a team-based grade, and it accounts each session as 4% of their grade, 4 sessions, so 16% of their grade is based on what their team does. So it's important that they're there. And they self-police this for attendance, because if their team member isn't there, they're losing out on someone to help find the answer, okay? So that's useful. The actual vignettes are not given to the students, but we do follow up each vignette with some content, and they're given that content after the fact, okay? So they have something to study from and something to go back. It ends up that we have about 8 minutes for each of these cases on average. Some don't take that long. Some, their discussion goes on a lot longer. And so here's a sample vignette for you here. We would put this up and we would read it. 36-year-old woman with Crohn's disease presents with a 2-month history of worsening right lower quadrant abdominal pain, a 1-week history of fevers. CT imaging reveals stricturing ileal disease and an ileocolonic fistula. She undergoes ileal resection and primary anastomoses of the jejunum to the cecum. Patient will most likely experience which of the following physiologic effects? So now the students are on their own. They're going to go to the things they've done in the past week. They're going to look at the ebook chapters. They're going to talk it over, and they're going to try to decide which of these answers is the correct answer. One of the team members has been designated the one to submit the grade for the team, and they're going to type in that answer. Now, while this is going on, the 2 co-directors tend to roam amongst the students. We're available. We'll answer questions. We'll try to help them a little bit in understanding what's going on, but this is a great opportunity for the students to start to synthesize. One of the complaints we get is that you spend 14 hours on physiology and we don't get any physiology questions. How many of you recognize this is just a flat-out physiology question, okay? This isn't, really a clinical question, but it's disguised. And they think this is, well, why did you teach us basic physiology? Because basic physiology allows you to answer 40% of the vignettes that we put up. You don't have to know clinical medicine, all right? So after they have a chance to talk about this, we will put up the correct answer, and we do this with Turning Point, and we poll, and we know what their responses are. If 100% of the class picks C as the correct answer, we've lost the ileum. We can't absorb bile salts, so we know the bile salt levels are low. We can't emulsify fats. All right, pretty simple, straightforward question. If everyone gets it right, we're in good shape. But if they don't, then this is the content we would put up after the fact and say, okay, these are the things important in the digestion of carbohydrates. These are the things important in the digestion of fats. These are the things important in the digestion of protein. And so it gives us an opportunity to sort of synthesize and review content. This slide will be given to them after the lecture as part of, you guys need to know and understand these are important concepts that become very important as we go along. There are 2 activities that I do near the end of the course that students rate very highly and appreciate, and it is basically an opportunity for them to think about the process as a whole. And when I do an integrated response to a meal, I'm always wearing my good integrated response to a meal tie, all right? So that they're thinking, what really happens here? And so we'll go through initially, those of you that have taught physiology, oftentimes they'll talk about an interdigestive phase, a cephalic phase, a gastric phase, and an intestinal phase, all in an effort to help you consolidate what's going on at that particular point in time. And so I'll go down through the gut, what's going on in the interdigestive phase. So I'm going to assume that you guys were so anxious to get here this morning at 8 o'clock that you forewent breakfast, okay? You haven't had anything to eat from last night. And so here you are, you're here, and your interdigestive phase, your gut, your GI tract is relatively empty. Now, I'm sure Dr. Collins is going to tell us it's not empty. There's lots of things going on, okay? So stay tuned for that. But from a physiological point of view, we sort of say, well, it's pretty much empty and you're done. So what is happening at the level of the mouth? Are you producing any saliva? Yeah, a little bit. You're awake. You're producing some saliva, all right? What's the pH of it? Well, here students always get confused because they know the pH of saliva is basic, right? But at rest, it's actually a little bit acidic, okay? Are you making any enzymes and secreting any enzymes? Yeah, you guys are hopeful you're going to get some breakfast soon, okay? So your salivary glands say, I'm going to make some enzymes anyway, all right? Are you making some mucus? Yeah, it's important to be making some mucus. Protect that lining because you don't know when you may slurp some Jell-O, okay? We work on down our way through this, looking at what's happening at each level as we go along. And so I've shown for you here just basically what's happening at the level of the mouth and the stomach. And then we will move on. And at this point, I'm ready to start to talk about the cephalic phase. And so here I will usually take in a couple bags of cookies, and I'll pull out a bag of Oreos and go, who would like an Oreo? Who would like a ginger snap? Who would like, and I'll have these 3 bags open, and I'll say, okay, has the cephalic phase begun? And they'll grudgingly admit, yeah, I'm salivating. They recognize I'm doing it, okay? And so why are you salivating? Well, you got neural signals. The thought of food, the smell, the taste, the anticipation, all of these things are combining. How are you getting the signal out to the gut? Parasympathetic nervous system, vagus nerve, all right? So what's happening at the salivary glands? Well, everyone agrees we're making more saliva. At this point, I'll probably say, well, you guys are already in cephalic phase. I don't have to give you a cookie, do I? And that's greeted with a chorus of boos. And so, we'll start the cookies out. Okay, you guys are getting cookies. And we'll go down through what's happening at each level, okay? The reality is, if you guys are like me, a lot of your teaching, you give them all these factoids, but you don't take time to put them together. And students certainly don't take time to put them together. This forces them to think globally. Okay, what is really going on? What's happening at each of these levels? Okay? And so we'll work down through the cephalic phase. And then we'll move into the gastric phase. Okay, what's happening in the gastric phase? Well, now we've got food. That cookie has actually made it to your stomach. What's going on? And we'll work down through it. We'll work into the intestinal phase. And for any of you that are interested in these, we'll make sure this material gets provided to the APS and you can have these things for your use as well. One of the things I would like to point out is that as you look down through this, you can see as you move from the cephalic phase to the gastric phase, things move downward. Okay. There you go. That's right. So as you look here, you can see that as you move from cephalic to gastric to intestinal phase, the number of pluses here, the relative effect is changing very much, and it makes perfect sense. That's where the food is, that's what's going on. And we talk about these interactions, why is the gastric tending to decrease a little bit by the time you get to the intestinal phase? Well, you've got some feedback. You've got hormonal things that are occurring. And so this gives students a way to put all this information together and understand it, hopefully, much more effectively. So that's one of the integrated things that I do. The other integrated thing that I do has to do with cystic fibrosis. And recognize when by the time they're in their second year of medical school, they've heard about cystic fibrosis a couple dozen times. And they know lots of factoids about cystic fibrosis. We'll talk very briefly, what's the basic defect? Got a chloride channel conductance problem, right? Well, how does that contribute to all the symptoms? And so I'll ask them, give me some of the symptoms, some of the things that you associate with cystic fibrosis. And here's a list that the students created. These are things they gave me. This is what I might see in cystic fibrosis. And so we'll make this extensive list of things, and I always get a kick out of the fact that, night blindness is something you associate with a chloride defect. Why? Why is that a symptom? Well, then we'll begin to work through what's really going on. And this is part of a flow chart that we'll develop. But we have here, you've got a problem with chloride transport. As a result, you end up with thick mucus. Okay? So they're with you on that. They've heard that before. That's making sense to them. And now you go, okay, so what happens with that thick mucus? Well, if you think about thick mucus, what happens? It blocks things up, right? Thick mucus doesn't move very well. And so it may cause an obstruction. If it blocks the pancreatic duct, what's going to happen upstream? You got nasty things being secreted by the pancreas, right? You can end up with autodigestion of the pancreas. Significant problems there. And if you digest the pancreas, not only do you lose the exocrine pancreas, but you lose the endocrine pancreas. And so diabetes mellitus is a common sequence, a common symptom that may be associated with a cystic fibrotic patient. And that's the simple mechanism, okay? Well, that's what happens upstream. What's going to happen downstream? Well, downstream, if you have an occluded duct, you're not going to secrete bicarbonate. Pancreas is making it, but it's not going downstream. So what happens? Well, you don't neutralize stomach acid, you end up with duodenal ulcers. All right? You also don't have your pancreatic enzyme secretion. So you have a failure to do a lot of absorption and things. And so we have these significant problems that occur. As we go through this, we'll develop it more. And I will point out to them that, we have some things that are, this is now, we have an obstruction in the bile duct, okay? The backup can cause biliary cirrhosis. That has a whole list of things associated with that. Here's the loss of these pancreatic enzymes and all the problems associated with that. And let's see, down here, where's my night blindness? Right here. We don't absorb vitamin A because it's a fat-soluble vitamin, and a lack of vitamin A leads to night blindness. And so we have all these different vitamin deficiencies, all of these things that can be associated with that. In developing this, and here's the entire chart that we develop as we work through it. I typically spend 30 to 40 minutes developing this and working through it with them. But they get excited about it, and they start to say, well, what about this, and what about this? And so it's a very effective way of getting them to consolidate all of this information, to really start to put it together and to think at the big picture. Not just, oh, this is what this enzyme does, but this is why it's important as we go along, all right? So, that gives you two strategies, two things that I've used, and quite honestly, these are the two things that the students remember from the course. They, years later, they say, I remember thinking through that cystic fibrosis case, I remember that integrated response, because that helped me understand the big picture, all right? And so I suggest to you that those are things that you may be interested in incorporating. Again, very happy to provide those materials to you. Final thought here is basically, with enough thought about what you're doing and enough input, even a respiratory neurophysiologist becomes known as the GI guy, all right? The more you can do to engage your students, to get them involved, the better off you're going to be. And so with that, I am happy to answer any questions that you guys may have. Any questions? And do please come to the microphone. Thank you. It should be on, they say. Try this one. If it's not working, they'll be closer and they'll get there quicker.
Hello. Okay, so you're doing TBL. Are you doing that in the Mickelson model where they're doing the IRATs, TRATs, and
No.
then application exercise? So you're
No.
not doing traditional TBL?
No, we're not doing that traditional model with the initial IRAT. This is strictly a team-based activity, and so we're basically putting that vignette up,
Okay.
and they're talking about it. We're circulating through. They're using whatever resources they have available. So all of them have their laptop open. All of them are trying to find things out. They're talking about it, and they're deciding what are we going to answer as a team.
Okay, and then how do you assign that grade?
So the grade is assigned basically on the team performance. Now, our experience has been most of the groups are going to get 18 or 19 of the 20 vignettes correct.
Okay.
And so they end up with ranges from about 70% for teams up to 100%.
Okay,
for
so
the
the
teams.
grade is based on the correct choice.
The team
answered.
performance and the correct choice, yes.
Okay, thank you.
And we do come back sometimes, they present a pretty good argument for the vignette that, well, couldn't it be this? And then we will go back and say, okay, I hadn't looked at it that way. It's like any other exam,
Yeah, medical students like to argue.
Medical students love to argue.
Thanks.
We have several in our class that are law school graduates, and they're very effective at arguing their point. Any other questions? Yes?
Just really quick on the end of that. So do you do new cases every year? Because I know our students would have them within a heartbeat.
Yeah,
If you didn't do new
we
ones.
have an honor code that basically says they're not to provide them, and we do not release those. We are concerned what's going to happen when we send them off campus to the other campus. Are we going to be able to keep them confidential there? That is a bit of a concern. We think we're good for that. But what we tend to do is, and these things are coming so quickly that, could they take a screenshot and save it? They're not getting that onto their computer.
Okay.
They're only getting it projected onto the screen.
And they like to use their phones for that.
So they can use their phones to take that picture. But remember, we're circulating, and we would say, yeah, you don't want to be taking a picture of that.
I actually had another question before that
Sure.
one came up. When you do your cumulative kind of phases of digestion review,
Yeah.
do you let the students do any active stuff before you almost put it back into a traditional lecture?
Yeah, actually, what I will do there is I won't have any of those filled in. I'll say, what's happening to the volume of saliva in the interdigestive phase? And I'll let them talk about it a little bit, and then I'll uncover my answer, okay? And I will say, I've learned that one of the best answers to any question in physiology is, it depends. And so, they'll say, well, couldn't it be this? Well, if the conditions are right, absolutely. You got to look at what's the whole big picture. And I emphasize to them, things change. You're in the middle of eating a meal and you get scared real badly. What's going to happen? It's going to change. You're busy eating, your bagel, and someone asks you a question and you panic. What happens to saliva production? Well, it turns from a watery-based electrolytic secretion to a mucus-based secretion pretty quickly, and you get a dry, sticky mouth, right? Because you turned off the parasympathetic and turned on the sympathetic. So we tend to do that. Any other questions?